Hello everyone, I'm Dr. Chanda Rai, consultant gynecologist, and in this video I'll talk to you about ectopic pregnancy. What is it? What are the factors which cause it, the risk factors associated, and the clinical presentation in such a case. So let's start. Now I'm going to draw the picture of a uterus. These are the two tubes, the fimbria, the ovary, which is attached by a suspensory ligament along the cornual end of the uterus and suspended to the lateral pelvic wall by means of infundibulopelvic ligament. Similarly on the other side. Okay, so what happens in a normal pregnancy is when ovulation happens, the egg or the ova is released by the ovary and it is caught by the fimbrial end of the tube and it travels up the tube and the egg stays somewhere here. After an intercourse, what happens is the sperms will ascend up the vagina, enter into the cervical canal and into the endometrial cavity. So it will traverse up, then it will travel up the tube, meet the ova somewhere here and fertilize the ovum, resulting in an embryo. Now if some problem has occurred in the tube, if the tube is distorted in its morphology or there is some sort of constriction which has blocked the tube, the ovum, fertilized ovum will not fall back into the endometrial cavity. So normally what happens is a fertilized ovum will travel back into the endometrial cavity of the uterus and implant somewhere here, resulting in a normal intrauterine pregnancy. But what happens in an ectopic is because the tube is distorted, it is blocked somewhere, the ovum cannot travel back into the endometrial cavity, resulting in an ectopic. So that is the reason why most ectopics you can see inside the fallopian tube. More than 90% of the ectopics, they occur in the fallopian tube. So just to recapitulate what has been already said, that ectopic pregnancy lies outside the endometrial cavity of the uterus or it's extrauterine. Definition is very important because it will give you a quick idea about the chapter, what it is about. So you must remember the definition. So ectopic pregnancy is the implantation of an embryo outside of the uterine cavity and the most common site is the fallopian tube. Here the fetus can attach to any abnormal part of the uterus like an abnormal tube or scarred portion of the uterus. Where can you see a scarred portion on the uterus? Most commonly a C-section scar. Okay, so how common are ectopic pregnancies? Ectopic pregnancies occur in about 1% of all pregnancies. So out of 100 women in the reproductive age group that you come across, one woman can have an ectopic. So it's quite a common phenomena and you must not miss out on this. So any reproductive woman who so any woman who has come to you in her reproductive age group, you need to screen her pregnancy test if she has come with any menstrual irregularities, pain, abdomen. Okay, you should not miss out on ectopic. Why should you know about ectopic pregnancy? So ectopic pregnancy is a known complication of pregnancy and it carries a high rate of morbidity and mortality. Okay, especially in the first trimester. In the first trimester, this is the leading cause of maternal mortality. So what happens when an ectopic occurs in the tube? It is not as expansile as the uterine cavity. So what happens with the fertilized ovum is it will corrode the tube. It will grow inside and gradually corrode the tube and burst outside, resulting in a hemoperitoneum. Okay, so the blood will collect inside the abdominal cavity, and this becomes life-threatening if it is not detected at the proper stage. And it is a medical emergency. You need to act upon it quickly. Okay, what is the physiology behind it? So the fallopian tubes will assist in the transport of an oocyte and an embryo. What helps in the transport is the smooth muscles which contract, smooth muscles lining the wall of the tube which contract, and the cilia which beat at regular intervals, thus propelling the oocyte and the embryo to travel back into the uterus. Any damage to the fallopian tubes, and when will it damage? And it's commonly seen secondary to any sort of inflammation, will produce tubal dysfunction. What happens is in inflammation is, if the tubes are inflamed, that condition is known as salpingitis. Okay. An end result of any inflammation is always fibrosis. Adhesions, fibrosis. So this will block the tube. Any blockage will again subsequently lead to an ectopic. In this cross section of the tube, you can see the inner lining of the tube is by the mucosal folds. So this is the mucosa which lines the inner surface of the tube, and outside muscularis layer. Okay, so ectopic, if it grows inside, it will grow gradually into the muscularis and then breach the serosa of the tube, leading to a hemoperitoneum. Now you must remember the common sites of an ectopic. So what are the common sites? Most common, I have already told you, is the fallopian tube. More than 90% of the pregnancies will occur in the tube. This you must remember. This will be followed by an interstitial or a cornual pregnancy. What is interstitial? Anything which is just lateral to the, or the lateral most part of the tube is the interstitial portion of the tube. Okay, so interstitial or the cornual end of the uterus is the next common site, which constitutes around 3%. So any ectopic, if it occurs here, it will bleed a lot because it is lodged inside the muscular part of the uterus. So if we are removing it or cutting across it, then also it will bleed a lot during the surgery. So we need to be careful about that and keep that in mind. And if we come down from below, the other sites of ectopic will be a cervical part. Okay, it can be a cervical ectopic, it can be a C-section scar ectopic. Okay, it can be an intramural or lodging in the myometrium of the uterus. So all these will constitute around 1%. Okay, the rare kinds of ectopic are ovarian ectopic, which is very rare, around 1%. It will be less than 1%. And heterotopic pregnancies are those pregnancies which have two sides. Like one pregnancy can occur in the can be a normal intrauterine pregnancy occurring in the endometrial cavity, and the other pregnancy lying in the tube. So both these sites will make a heterotopic pregnancy. And where is it commonly seen? These heterotopic pregnancies are commonly seen in IVF pregnancies. What happens in an IVF is an infertility specialist will take a syringe to push the fertilized ova inside the cervix, and it so happens that sometimes more than one embryo is also pushed inside. So 2 or 3 embryos can be pushed inside. One of them can lodge here in the endometrial cavity, and the other, if the pressure is too much, because you cannot control it, it's iatrogenic basically, so the other pregnancy can happen somewhere here in the tube. So both the simultaneous lodgement of the pregnancies can result in a heterotopic pregnancy. Okay, sometimes it can be an abdominal pregnancy also, that sometimes the embryo has come into the peritoneal cavity and very rarely it can grow to a full-term baby also. Okay, and these are also very rare conditions. What happens in a C-section ectopic? This is also grown very common nowadays because of the increasing rates of C-section carried out throughout the country. So what happens is the C-section scar on the uterus will create some sort of a defect, some sort of a gap in the myometrium, in the endometrium and the myometrium of the uterus. So this C-section scar occurs on the lower uterine segment. Here the pregnancy, the ovum can go and sit inside the gap somewhere here, resulting in a scar ectopic. Okay. So just to summarize again, the most common site is the fallopian tube, more than 90%, followed by the cornual pregnancies and or in the interstitial portion of the tube. Then you come down from below, the cervical, the C-section scar pregnancy, the intramural pregnancy, and then followed by rare sites are ovarian and heterotopic pregnancy. Okay. 1 to 3%, rest all pregnancies will comprise between 1 to 3% of all ectopics. So what are the risk factors? So as you have understood the physiology now, you know that anything that can block the tube, any sort of inflammation which can block the tube will constitute the risk factors for ectopic. So what are the factors which can cause inflammation to the tube? So any salpingitis that is caused by most commonly PID. Pelvic inflammatory disease will inflame the tube leading to PID. Okay. This PID can also be due to sexually transmitted infections. Okay. Any sexually transmitted infection will again climb up the cervix, enter the uterus and then affect the tube and also the ovaries. So this will also result in an ectopic. Okay, so PID, STIs, this is how you can make out. And then HIV, okay, that is also a STI also, STI only. Then it can also be tubercular salpingitis. Tuberculosis is a very common condition in our country. So any tubercular salpingitis will also result in blockage of the tube, and it is a very common cause of infertility in our country. Okay. So the risk factors will include any sort of previous ectopic. Okay. So any ectopic, if anybody who has had an ectopic before is prone to having an ectopic again. Any fallopian tube surgery. So any surgery on the tube will again produce certain sort of adhesions in it in the tube causing an ectopic. Any previous abdominopelvic surgery carried out before. So I have already told you about STIs, PID, tuberculosis. Also another common thing which is happening now is this is having an upsurge now is that of endometriosis. It is also an inflammatory condition where the tube will have cicatricial inflammation and resulting in fibrosis ultimately. Okay, and any sort of ART, IVF, infertility. Infertility, why? Because infertility, any tubal blockage will commonly lead to infertility and ART, IVF. IVF also can lead to an ectopic. I have already discussed with you before. And another important thing is that of all the patients, half of them may not have any risk factors. Okay, they might not have any risk factors. So that is also probable. Some patients might ask you, why did I have an ectopic? There's no you may not be able to explain any reason, so it can be etiopathic also. Okay, what are the clinical features associated with it? So any woman in her reproductive age group, that is important. She should be in her reproductive age group. Okay, so any woman who is sexually active has irregular bleeding PV. Okay, you must check her urine to look for pregnancy. You must rule out pregnancy in any reproductive woman who has come to you with irregular bleeding PV. So she may or may not have missed her periods. Okay, that's an important thing in pregnancy because sometimes there can be an intermenstrual bleed, and you keep on thinking that it's a normal menses, but this is not so. It could be an ectopic pregnancy also. So anyone who has come with you to you with irregular bleeding PV must rule out pregnancy. She can have pain abdomen. It's a very common clinical feature. One is irregular bleeding PV. Secondly, she can have pain abdomen. Okay, because when the ectopic pregnancy ruptures inside the tube, it will cause pain. Also, when the blood collects into the abdominal cavity, it will distend the peritoneum, irritate it, and causing pain. Okay, so these things are signs of a tubal rupture. Third, she can have giddiness or fainting because of too much blood loss. She can become anemic, leading to giddiness and fainting. So these are the very common symptoms, most common symptoms that a woman with ectopic will present to you in an emergency. So irregular bleeding PV, pain abdomen, giddiness and fainting. Okay, so she can come to you with abdominal pain, vaginal bleeding. Okay, vaginal bleeding is usually slight. Most commonly, the vaginal bleeding will be slight. Most blood collection is inside the peritoneal cavity. She can have syncope, nausea, vomiting also less common. So if patients have missed their last period or have abnormal uterine bleeding, and are sexually active, then they may be pregnant and thus need further testing with a pregnancy test. Any reproductive age group woman coming to you with missed periods or irregular bleeding PV must check her UPT. So what are the signs that the woman can come to you with? So because of the loss of blood, there will be an increase in the pulse rate and a low BP. This is also, when you examine the patient, you will see that she has a tachycardia and her BP is very low in the range of 90, 60, even less than that, 80, 60. So you have to immediately resuscitate the woman. Immediately give her fluids. IV fluids is to be given immediately, followed by arrangement of blood. So, okay. She'll have pallor. Okay, so general examination, what do you see? General examination will see, from top to bottom, if you go, you'll see, look for pallor, icterus, cyanosis, pedal edema. So out of them, pallor will be positive. Vitals, if you check for the vitals, pulse rate will be high, BP will be low. Okay, SpO2 may have fallen. Okay, because of the loss of blood. So the oxygen carrying capacity of the blood will also decrease, resulting in a low SpO2. Okay, so per abdomen she can have, because of the collection of the blood, it can be tense. It will be a tense abdomen, distended abdomen. Okay, guarding or rigidity will be present. When you press her abdomen, when you palpate her abdomen, the muscles will contract. So showing that the guarding or rigidity is positive. So it will be abdominal. So when you examine her abdomen, there can be distension, there can be guarding, rigidity and tenderness. So all these things will be positive. Tenderness will be positive, guarding, rigidity will be positive. When you do a per speculum examination, when you have put a cusco speculum and into the vagina and have a look at the cervix, there can be bleeding, some sort of minimal bleeding PV from the cervix. Okay, from the cervix. When you do a bimanual examination, okay, the positive findings would include an adnexal mass and tenderness in the fornices. So how do you do a bimanual examination? It means bimanual, that is you are using both your hands. Okay. So bimanual means one hand will go, your two fingers will go inside the vagina, okay, and come close to the cervix. The other hand will go on the abdomen and try to palpate the uterus in between the two hands, okay. So when you feel the uterus in a normal, if it is an enlarged pregnancy, if it is a normal intrauterine pregnancy, it will be an enlarged uterus. The uterine size will increase. It will become soft. Okay, it can be an 8 weeks, 10 weeks size uterus. Uterus will be soft to touch. When it is an ectopic pregnancy, the uterus will be usually of normal size. Okay, it will be a normal size uterus. And when you go on the sides, when you palpate the sides, because of an ectopic, if the ectopic pregnancy in the tube has lodged here, it will be, you will feel it will be enlarged. You can feel an adnexal mass. You can feel an adnexal mass which will be tender to touch. Okay, the adnexal mass will be tender to touch. So you say the fornices are tender. There is fornicial tenderness. Okay. So that is what you see on a clinical examination. You palpate the abdomen, look for the tenderness, the distension in the abdomen, there can be rigidity, and you can do a PV examination, a bimanual examination where you can look for the adnexal mass and fornicial tenderness. So this is all for this video. In the next part, I'll be discussing about how to diagnose an ectopic pregnancy, how to manage it, and also some questions which are frequently asked. So thank you very much for listening.